Okay, hi everyone. I think I'll start with the session. I'm taking today's session as Dimple will be taking She's Walk with me. So we'll be doing biochemistry, metabolism. Uh, so page number is 71. 2022. So first starting with the enzyme terminology. Is everyone able to hear? Is the audio okay?
Yes, sir.
Yes, sir.
Okay. So first enzyme terminology, kinase. Kinase is where you always have a transfer of phosphate groups and it's usually ATP. Phosphorylase, it's a enzyme used for adding inorganic phosphate onto substrate without using ATP. So kinase is with ATP and phosphorylase is without. Phosphatase is which removes the phosphate group, and dehydrogenase is usually in the reaction of oxidation reduction. Hydrolase is adding hydroxyl group, and carboxylase is transferring of carbon dioxide group, and it usually requires the biotin, that is B7 as cofactor. Mutase is specially for relocation of functional group within a molecule. So the very important vitamin here is vitamin B12. Excuse me 1 second. Yes, sorry. Okay. Now moving on to rate determining enzymes of metabolic process. First, in glycolysis, you have PFK1, and all the irreversible steps are basically rate determining. And in gluconeogenesis, the important one is fructose 1,6 bisphosphatase. TCA cycle, isocitrate dehydrogenase. Glycogenesis, you have glucogen synthase. Glycogenolysis is glycogen phosphorylase. HMP shunt is G6PD. And in de novo pyrimidine synthesis, you have CPS2. And de novo purine synthesis, it is PRPP. In urea cycle, it is CPS1. And fatty acid synthesis, you have acyl-CoA carboxylase. Fatty acid oxidation, that is carnitine acyl transferase. Ketogenesis is HMG-CoA synthase, and cholesterol synthesis is HMG-CoA reductase. And thumb rule is when you have increased breakdown of ATP products, you'll have AMP and AMP ADP. So these all inhibit the glycolysis pathway. And when you have, they all stimulate the glycolysis pathway, whereas ATP, citrate all inhibit the glycolysis pathway. And next, metabolism sites. So here important mitochondria and cytoplasm. So in mitochondria, you have fatty acid oxidation, acetyl-CoA production, TCA cycle, oxidative phosphorylation, ketogenesis. In cytoplasm, it is the glycolysis, HMP shunt, synthesis of cholesterol, proteins, fatty acids, and nucleotides. Both occurs in heme synthesis, urea cycle, gluconeogenesis. Next, moving on to the next page, ATP production. So aerobic metabolism will yield 32 net ATP via the malate aspartate shuttle. but 30 ATP via glycerol 3-phosphate shuttle, which is in the muscle. And anaerobic yields only 2 ATP. And so here, clinical point is arsenic causes glycolysis to produce 0 net ATP. So if you have arsenic poisoning, you'll have net 0 ATP production. Next, moving on to activated carriers. So ATP is used in phosphoryl groups. You have phosphoryl groups in ATP, and NADH, NADPH, FADH2 transfer the electrons. CoA, lipomide carry the acyl groups. Biotin is for carbon dioxide. Tetrahydrofolate, THF, carries 1 carbon unit. SAM, that is S-adenylmethionine, carries the CH3 groups. Next is universal electron acceptors. So you have NAD plus and NADPH. NAD plus is used in catabolic process, whereas DPH is used in anabolic process such as steroid and fatty acid synthesis. And NADPH mainly is used in these 4. These are important to remember. That is anabolic process, respiratory burst, cytochrome P450 system, and glutathione reductase. Next, hexokinase versus glucokinase. So here, glucokinase is used by the liver and beta cells of pancreas, whereas hexokinase is in the most tissues except where glucokinase is used. And Km and Vmax is both increased in glucokinase, whereas in hexokinase, Km is increased and Vmax is decreased. So, and induced by insulin, only glucokinase is induced by insulin. Next, glycolysis regulation key enzymes. So here so these are the irreversible steps. That is hexokinase, glucokinase, which cause glucose to glucose 6-phosphate. And next is PFK1. And next, which require ATP is the glucokinase for PFK1, and which produce ATP is phosphoglycerate kinase and pyruvate kinase. Next, moving on to regulation by 2,6 bisphosphate. So this is an important regulator of glycolysis, where in fasting state, you have increased glucagon, which causes increased CMP, and in turn will cause increased protein kinase A. So this protein kinase A will cause increase in FBP2 and decrease in PFK2. So you will have less glycolysis and more gluconeogenesis. Whereas in the fed state, you'll have increased insulin. So this will cause decrease in CAMP and decrease protein kinase A. So you'll have increase in PFK2. So you'll have it'll be favorable for glycolysis. And next is pyruvate dehydrogenase complex. So here important point is that you have to remember the 5 cofactors involved here. That is B1, B2, B5, B3, and lipoic acid. And any deficiency in these enzymes would cause decrease in glycolysis, so TCA cycle. Next, moving on to pyruvate dehydrogenase complex. So if there's a deficiency of this enzyme, this enzyme is needed for conversion of pyruvate to acetyl-CoA. So if this is not present, then it is shifted to lactate or alanine via the lactate cycle, that is Cori cycle, or the alanine, that is Cahill cycle. So in the question, you'll have increase in LDH and alanine, also with hypoglycemic symptoms. Treatment is you give increased ketogenic nutrients, that is high fat content, or increased lysine and leucine. Next, in pyruvate metabolism. So here, the alanine aminotransferase requires the B6, whereas the pyruvate carboxylase enzyme, alanine is involved in the alanine cycle, and pyruvate carboxylase requires the B7, and pyruvate dehydrogenase all the 5, and lactic dehydrogenase is B3, and LDH is the major pathway in RBC. Lactic acid dehydrogenase enzyme is majorly used in RBC, WBC, kidney, medulla, lens, testis, and cornea, where it involves anaerobic glycolysis. Next, TCA cycle. In TCA cycle, Krebs cycle basically it forms from pyruvate to acetyl-CoA. So you have production of one NADH and one carbon dioxide. So the reaction from pyruvate to acetyl-CoA produces one NADH and one carbon dioxide. So here the ultimatum is you have 10 ATP production, and this occurs in mitochondria. And this requires the major enzyme, that is alpha ketoglutarate dehydrogenase complex. Again, dehydrogenase complex containing the 5 enzymes. Next, moving on to electron transfer chain and oxidative phosphorylation. So here the important ones is to remember the complex and which drugs block them. So for complex 1, you have rotenone and metformin, which blocks complex 1, and complex 3 has antimycin. Complex 4 has all the ide, that is cyanide, carbon monoxide, and cyanide, carbon monoxide. Next is complex 5, you have oligomycin, which inhibits complex 5. And also here an important thing is the uncoupling agents, which is 2,4 dinitrophenol and aspirin overdose. This causes increase in permeability of the membrane, causing decrease in proton gradient and increase in O2 consumption. So this ratio is increased O2 consumption. So you'll have ATP synthesis stops, but you'll have production of heat, and which is physiological when you have when in the newborns containing thermogenin in brown fat. Next is glyconeogenesis. Here, all these enzymes may be subject to activation by glucagon in fasting state. So these are pyruvate carboxylase, phosphoenol pyruvate carboxykinase, fructose 1,6 bisphosphatase 1, glucose 6 phosphatase. Next, so this primarily occurs in livers and maintain euglycemic during the fasting state. These enzymes are also found in kidney and intestinal epithelium. Deficiency of these key glucogenic enzymes will cause hypoglycemia. And here important point is that odd chain fatty acid yields 1-propenyl-CoA during metabolism, which can enter the TCA cycle. Odd chain can enter the TCA cycle to make glucose. And so this undergoes gluconeogenesis and serves as glucose source. So even chain cannot produce new glucose, and since they yield only acetyl-CoA equivalents. Next, pentose phosphate pathway. So here, this is also known as HMP shunt, where this is the source of NADPH. Example is glutathione reduction inside the RBC, fatty acid, and cholesterol biosynthesis. This yields a ribose for nucleotide synthesis. And HMP shunt is where the PRPP joins for 5-ribulose. Next is oxidative and non-oxidative reactions. So here in the HMP shunt, you have ribulose 5-phosphate, which joins the here the important enzyme is transketolase B1 and G6PD. Next is in so going on to the G6PD, you have if you have G6PD deficiency, you have so NADPH is imported to keep the glutathione reduced, and which detoxifies free radicals and is an important for RBC. If it's absent, then you'll have hemolytic anemia because there will be no defense against the oxidative reagents such as fava beans, sulfonamides, nitrofurantoin, primaquine, chloroquine, and anti-TB drugs. Also, these are mainly X-linked recessive disorder, and you can have Heinz bodies and White cells in the peripheral blood smear. Next, moving on to the disorders of fructose metabolism. So here, anything with kinase is mild, and the other aldose B is the severe one. So when you have first one, formation of fructose to fructose 1-phosphate, so the fructokinase is involved. And the symptoms here are generally mild, benign, where because there's no fructose trapping inside the cells, so there's no any megaly or anything, as the fructose can be converted into, can be broken down in other pathways. So there's no accumulation. Symptoms will be fructose appears in blood and urine, and this is usually on a test or something identified on a regular basis. Disorders of fructose metabolism cause milder symptoms. Next, hereditary fructose intolerance. Here you have the major aldolase B, where fructose 1-phosphate accumulates, and this will cause jaundice and jaundice cirrhosis, with also you'll have symptoms of hypoglycemia. And this usually, the case would be like, this occurs after a consumption of fruit juice or honey, and they would give the urine dipstick negative for glucose and positive for reducing sugar. Treatment is decrease intake of fructose, sucrose, and sorbitol. This is a question. So next is galactose metabolism. So here the disorders would be galactokinase deficiency and classic galactosemia. In galactokinase, again, kinase is a milder form. So here you will have a galactose accumulation. Symptoms would be galactose, which appears in blood and urine. So galactosuria and galactosemia, infantile cataracts, and baby symptoms can be a failure to track objects, develop a smile, and it's usually benign. Whereas classic galactosemia have a deficiency in G1 put. So damage damage is due to the accumulation of the toxic substance because it's already converted. And this is the second enzyme which is deficient, and you'll have accumulation in the lens and present lactose. So this usually develops in infant because lactose is present in breast milk and routine formula. So this includes failure to thrive, jaundice, hepatomegaly, infantile cataract, and intellectual disability. Treatment would be to exclude galactose and lactose from the diet, as lactose has both as galactose plus glucose. Next, sorbitol. Sorbitol, this is an alternate method of trapping glucose. So it is to convert its alcohol counterpart sorbitol via the aldose reductase. So glucose is converted into sorbitol, and sorbitol is converted into fructose. So if this last enzyme, that is sorbitol dehydrogenase, is deficient or decreased, then you'll have accumulation of sorbitol. And these pathways are generally seen in larks, that is lens, retina, kidneys, and Schwann cells. So the symptoms will be accordingly, such as cataracts, retinopathy, peripheral neuropathy, and chronic seen in chronic hyperglycemia when glucose takes this alternate route and gets accumulated with sorbitol. Next, lactase deficiency. So insufficient amount of lactase enzyme can cause dietary lactose intolerance. This can be due to two things. One is absence of the enzyme, and second, it can be due to an infection which causes villi atrophy, which slough offs the villi, so you'll have decreased enzyme for a benign time. So in primary, that is, you can have age-dependent decline after childhood. And next is in congenital lactase deficiency. It is rare and due to a defective gene. Here the stool demonstrates decreased pH, breath shows increased hydrogen with lactose hydrogen breath test. So the clinical findings would be bloating, cramps, flatulence, and osmotic diarrhea. Treatment is to avoid the dietary products, or can take the enzyme as lactase pills in the diet, or consume lactose-free milk. Next, moving on to amino acids. So here the essential acidic and basic amino acids which you have to remember. And next, moving on to urea cycle. So here you have excess nitrogen, which is converted to urea and excreted by the kidneys. So here the important enzymes are carbamyl phosphate and aspartate. Next, transport of ammonia by alanine. So always ammonia is transported by alanine. This is a point. And so the liver forms glucose when by the lactate and alanine both. Next, hyperammonia. Here you have so hyperammonia can be acquired or hereditary. In acquired, it is due to a liver disease. In hereditary, due to the enzyme, due to the urea cycle enzyme deficiency. So if the classical feature is flapping tremor, slurring of speech, somnolence, vomiting, cerebral edema, and blurring of vision. So increased in ammonia can cause alpha glutarate, glutamate, GABA, and glutamine to favor increased in glutamine. So this can cause CNS toxicity and may cause decreased GABA, alpha ketoglutarate, TCA, cycle inhibition, cerebral edema. Treatment is to limit the protein in the diet. And also you can give lactulose to acidify the GI tract and trap the NH4. So it's converting NH3 to NH4 so that it's trapped and doesn't get absorbed. As well as you can give antibiotics to kill the bacteria, which converts, which causes the conversion of ammonia. Next, ornithine transcarbamylase deficiency. Here, this is the most common urea cycle disorder, which is X-linked recessive. So the excess carbamyl phosphate is converted to orotic acid, and you'll have symptoms like hyperammonia and and there would be no megaloblastic anemia. This is an important finding when you compare it to orotic aciduria, where you'll have increase in orotic acid in that, along with megaloblastic anemia. Also, orotic acid will be found in blood and urine. Next, amino acid derivative. This is also very important that all the amino acid derivatives should be remembered. I think it's the mugging up part. Next, moving on to catecholamine synthesis and tyrosine catabolism. So here also, so if you have a PK, you can have PKU when you have deficient enzyme of phenylalanine hydroxylase, and the conversion of homogentic acid and malonyl acetic acid, where you have homogentic oxidase, you'll have alkaptonuria, and albinism, where dopa is converted to melanin, deficiency of tyrosinase. So in phenylketonuria, here tyrosine becomes essential because there is decreased in phenylalanine hydroxylase. BH4 is an so tetrahydrobaptin 4 deficiency can cause increase in phenylalanine. An increased phenylalanine in pregnant patients can cause fetal growth restriction, microcephaly, intellectual disability, congenital heart effects. So the screening is usually done after birth, and findings would be intellectual disability. Clinical findings would be intellectual disability, microcephaly, hyperpigmented skin, musty odor. Musty body odor is an important finding. And treatment would be to decrease phenylalanine and increase tyrosine in the diet. So examples are soya products, chicken, fish, milk. Also, tetrahydrobiopterin supplementation is an important point. And also a question where phenylketonuria patients should avoid the artificial sweeteners such as aspartame, which contains the phenylalanine. Next, maple syrup urine disease. Here you have the deficient of the enzyme branched amino. So this block degradation of this branched amino acid, that is isoleucine, leucine, and valine. And so the enzyme, due to the branched chain alpha keto acid dehydrogenase deficiency, which causes increase in alpha keto acids in the blood. Treatment is basically to give this, to restrict these enzymes, the amino acids, that is isoleucine, leucine, and valine. Also, thiamine supplementation is very important, as B1 is a cofactor for this dehydrogenase enzyme. Presentation would be vomiting, poor feeding, urine, which smells like maple syrup or burnt sugar, and which causes progressive neurological decline. Next, alkaptonuria. Here you have the deficiency of homogentisate oxidase, which is a degradative pathway of tyrosine to fumarate. So if you have this deficient enzyme, you'll have increase in homogentisate buildup products. So you'll have bluish black connective tissue because of this accumulation in connective tissue, ear, cartilage, and sclera. And urine will turn black on prolonged exposure to air. This usually is given in the question. And arthralgia is an important symptom due to this toxic buildup. Next, homocystinuria. In homocystinuria, you have causes are all the autosomal recessive. So the clinical findings would be osteoporosis, marfanoid, habitus, ocular changes, cardiovascular effects such as thrombosis and atherosclerosis, because and this is important, cardiovascular effect, as increase in homocysteine will cause thrombosis and atherosclerosis. So the deficiency of cystathione synthase, which also cystathione synthase, methionine synthase, and methionine tetrahydrofolate reductase. Next, cystinuria. In cystinuria, so this is a defect in the renal PCT, where you have loss of reabsorption of CoLA, that is cysteine, ornithine, lysine, and arginine. So you'll have excess cysteine in the urine, or you can see precipitation of hexagonal cysteine stones. Treatment would be urine alkalization, potassium citrate, and acetazolamide. Also, this cystinuria can cause cysteine stones. So you have to maintain good hydration and diet low in methionine. Next, organic acidemia. In organic acidemia, you have most commonly presence in infancy with poor feeding, vomiting, hypotonia, high anion gap. So this inhibits gluconeogenesis, inhibits urea cycle. So you'll have decreased fasting blood glucose with increased ketoacidosis, high anion gap, and you'll have hyperammonia. So in propionic acidemia, due to the propionyl CoA carboxylase deficiency, you'll have increased propionyl CoA and decrease in methylmalonic acid. Whereas in methylmalonic acidemia, due to the deficiency of methylmalonyl CoA mutase or vitamin B12, Here the treatment would be low protein diet and substance which metabolizes into propionyl CoA, that is valine, odd chain fatty acids, methionine, isoleucine, threonine, which is the vomit. Next, moving on to the glycogen regulation. So here important is the protein kinase A, which is involved in the breakdown of glycogen, whereas protein phosphatase is involved in the protein glycogen synthesis. And so the protein kinase A stimulates the glycogen phosphorylase, whereas the protein phosphatase would stimulate the glycogen synthase. So moving on to the glycogen storage disease. So you have von Gerg disease. Here the deficiency is G6 phosphatase. You'll have increase in glycogen in liver and kidneys, increased blood lactate, increased triglycerides, increased uric acid. Increased uric acid is important. And hepatomegaly. Treatment is usually with oral glucose cornstarch and avoidance of fructose and galactose. In Pompe, you have deficiency of alpha 1, 4 glucosidase, that is acid maltase. So here the important finding is cardiomyopathy. This is important as this is only one which presents with cardiomyopathy. Hypotonia, exercise intolerance, enlarged tongue, and systemic findings lead to early death. Next, CORI. This is similar to von Gerg but has the milder symptoms and a normal blood lactate levels, whereas in von Gerg, the important differentiating factor is increase in lactate levels. Here in CORI, you have debranching enzyme deficiency. In next, Anderson, this involves the branching enzyme deficiency. So most commonly presents with hepatomegaly, failure to thrive in early infancy. Other findings like infantile cirrhosis, muscular weakness, hypotonia, cardiomyopathy, and early death. In McCardle, this is easy to diagnose because you have symptoms of only muscle pain, muscles. That is after a case would be after a strenuous exercise. You'll have severe muscle cramps, myoglobinuria, and arrhythmia from electrolyte abnormalities. Here's skeletal muscle glycogen phosphorylase, that is myophosphorase is deficient. Next, moving on to lysosomal storage disease. Here, so the first one, Tay-Sachs. Tay-Sachs is usually you'll have a neurological problem with a cherry red spot, but you won't have any hepatosplenomegaly. Enzyme would be hexaminidase A deficiency. Next, in Fabry's. In Fabry's, the symptoms would be again neurological symptoms such as numbing, tingling, burning pain in hands and feet, which are painful, with presence of angiokeratomas, hypohidrosis, decrease in sweat. And the angiokeratomas are an important characteristic finding. The enzyme deficient would be alpha galactosidase A. And next, metachromatic leukodystrophy. This can cause central and peripheral demyelination. So you'll have symptoms like ataxia, dementia. Enzyme deficiency would be aryl sulfatase A. Krabbe, in Krabbe, you'll have again neurological peripheral neuropathy. And here you'll have destruction of oligodendrocytes. So you'll have developmental delay, optic atrophy, and globoid cells. So globoid cells is very characteristic on the biopsy. Enzyme deficiency would be galactocerebrosidase. Next, Gaucher disease. This is the most common one with hepatosplenomegaly, pancytopenia, and they can give like anemic symptoms, early bone pain, and in the biopsy you can have lipid-laden macrophages resembling a crumpled tissue paper. The enzyme deficient is glucocerebrosidase. In Niemann-Pick, this is similar to Tay-Sachs, but this does not have any hepatosplenomegaly, which is characteristic. I mean, this has hepatosplenomegaly, which differentiates it from Tay Sachs with the presence of cherry red spot. And here the enzyme deficiency is sphingomyelinase. Next, mucopolysaccharides. You have Hurler and Hunter. Hurler is more severe, and you'll have corneal clouding, hepatosplenomegaly, skeletal abnormalities, and airway obstruction. The death is usually seen in less than 10 years. Basically, the child doesn't survive more. And the death is mainly due to the cardiac complications such as MI. And here the enzyme is important, alpha L ironidase. Basically, this is a deficient of GAG, that is glucose aminoglycans. Next, in Hunter, so here the death would be in adolescent stage, and the patient would have aggressive with no corneal clouding, and the enzyme deficiency is iridonate and sulfatase. Next, fatty acid metabolism. Here important is the systemic primary carnitine deficiency, where you have no cellular uptake of carnitine, so you won't have any transfer of long chain fatty acids into the mitochondria, and this will cause toxic accumulation in the cytosol, which the symptoms would be weakness, hypotonia, hypoketotic hypoglycemia. This is important, the hypoketotic hypoglycemia, and you can have a dilated cardiomyopathy. Whereas in medium chain acyl CoA dehydrogenase deficiency, you will have decreased breakdown of fatty acids into acetyl CoA. So you'll have accumulation of fatty acyl carnitines in the blood. Again, the symptom hypoketotic hypoglycemia, which will cause vomiting, lethargy, seizures, coma, liver dysfunction, hyperammonia, and can lead to sudden death in infants. Next, moving on to the ketone bodies. Here, so this is ketone bodies are released when you have prolonged starvation and in diabetic ketoacidosis, where oxaloacetate is depleted for gluconeogenesis, or with chronic alcohol overuse, high NADH state, which leads to accumulation of oxaloacetate. So this will cause shunting it to malate. Here, important findings are when ketone bodies increased, you'll have acetone fruity odor, and in urine test, you'll have acetoacetate, but not beta hydroxybutyrate. RBC cannot utilize ketone bodies. This is an important point, as they strictly use glucose. And HMG CoA lyase for ketone, HMG CoA lyase for ketone body production, and HMG CoA reductase is used for cholesterol synthesis. And also, along with the RBCs, liver cannot use the ketones. Next, fasted versus fed state. So again, here important is hormone-sensitive lipase enzyme and lipoprotein lipase. So hormone-sensitive lipase is stimulated by epinephrine and glucagon, whereas LPL is stimulated by insulin. Next, moving on to metabolic fuel. Here, so the last which pathway is in which state. So in fed state, you have glycolysis and aerobic respiration. And during fasting, you'll have majority of hepatic glycogenolysis and adipose release of free fatty acids stimulated by glucagon and epinephrine during the fasting between the meal state. In starvation, this is after 1 day, you'll have hepatic glycogenolysis along with release of free fatty acids, uh, and there will be a shift of fuel from glucose to free fatty acids. Also, hepatic gluconeogenesis from the peripheral tissues such as lactate and alanine, and form the adipose tissue glycerol and propionyl-CoA, the only triacyl glycerol component that contributes to gluconeogenesis is the odd chain free fatty acids. Next, the starvation after 3 days is where ketone bodies becomes the main source of energy to the brain. So the excess store of adipose tissues determines the survival here. Glycogen reserves are usually depleted after 1 day, that is 24 hours. This is an important point. And RBCs lack mitochondria, therefore, again, they cannot use ketone bodies. Next is lipid transport. So in lipid transport, you have B48 apolipoprotein, which takes cholesterol esters, triglycerides, and along with vitamin A, D, E, K from the intestine. And with the chylomicrons, it goes into the thoracic duct and gets into the systemic circulation, where ApoB48 is broken down via lipoprotein lipase in the adipose tissue muscle. And after breaking down, the free fatty acids are taken into the muscle adipose tissue, whereas the remnant goes into the liver via ApoE by the endocytosis. And next, VLDL is secreted by hepatocytes by the lipoprotein B100. And next, moving on to key enzymes in lipid transport. So here, cholesterol ester transfer protein. This mediates the transfer of cholesterol esters to other lipoprotein particles. So I'll tell the only important ones. Hepatic lipase degrades the triglycerides and chylomicron remnants. HSL, hormone-sensitive lipase, promotes the gluconeogenesis by releasing glycerol. Lecithin cholesterol acyltransferase catalyzes esterification of 2/3 of plasma cholesterol. Lipoprotein lipase degrades the triglycerides in circulating chylomicrons and VLDL. Pancreatic lipase degrades the dietary triglycerides in small intestine. And PCSKL, which degrades the LDL receptors and causes increase in serum LDL. And the inhibition of this would cause increased LDL receptor recycling and decrease serum LDL. Next, major apolipoproteins. So you have E for the endocytosis, which takes up the remnant of chylomicrons. And A1 alpha is seen in HDL, which activates LCAT. C2 lipoprotein lipase uses as C2 as a cofactor. B48 is where chylomicrons are formed in the intestine and taken up by lymphatics. And B100 is where LDL receptors, I think VLDL receptors have the B100. So important lipoprotein functions. Chylomicron delivers dietary triglycerides to peripheral tissues. VLDL delivers hepatic triglycerides to peripheral tissues. IDL delivers triglycerides and cholesterol to liver. LDL delivers hepatic cholesterol to peripheral tissues. HDL mediates the reverse cholesterol transport from peripheral tissues to liver. Next, now going on to the deficiencies, beta lipoproteinemia. You have mutation in MTP which causes deficiency in B48, ApoB48 and ApoB100 containing lipoproteins. You'll have severe fat malabsorption, steatorrhea, failure to thrive because there's no one carrying the chylomicrons from the GIT into the lymphatics. And you can also have retinitis pigmentosa and spinocerebellar degeneration due to vitamin A deficiency, that is in later malabsorption causes, and progressive ataxia and acanthosis. Important here is intestinal biopsy, which shows lipid-laden enterocytes. Treatment would be restricting long-chain fatty acids. Next, in familial dyslipidemias, type 1, you have deficiency of lipoprotein lipase. So here chylomicrons are not degraded. So hence you'll have increase in chylomicrons, triglycerides, and cholesterol. Here important would be the pancreatitis, because wherever there's increase in triglycerides, hepatosplenomegaly, and xanthomas. Next, type 2 hypercholesteremia. Here you'll have defective LDL receptors or B100. So you'll have heterozygous will have cholesterol greater than 300, and homozygous will have greater than 700 milligrams per deciliter cholesterol. And the main important clinical finding, clinical cause is atherosclerosis and MI before the age of 20, along with the presence of xanthomas, corneal arcus, and tendon Achilles xanthomas. Next, type 3, dys-beta lipoproteinemia. Here you have defective ApoE. So the remnant of chylomicrons is not taken inside. Again, here this can cause premature atherosclerosis, tubuloeruptive, and palmar xanthomas. Next, type 4 hypertriglyceridemia. Here you have overproduction of VLDL, which causes increase in triglycerides above 1000. And again, important when the triglycerides are elevated is it causes pancreatitis, not atherosclerosis or MI. And here basically type 2 diabetes is also involved. So question with type 2 diabetes, hypertriglyceridemia would be type 4 familial dyslipidemias. I think that's it for today. Anybody has any questions? Hello?
No, sir.
Actually, my UWorld questions have there's no biochemistry left, so I think we won't be doing any questions. Or if somebody else can share the screen, and that's fine too. Or who has UWorld with biochemistry questions? Ria, anyone?
So actually my laptop is not working properly and I've joined from laptop. Like there's some glitch in my UWorld account also. Plus like the hardware of my laptop is not supporting right now. I have to buy a new one actually. So later I'll present. Right
No issues.
now
No
I
issues.
can't share a screen.
Fine then. I think that's it for today's session. We'll end the meeting.
Okay, thank you, sir.
Okay, sir.
Okay.
Thank you.
Thank you, everyone.